discussion on chronic disease and chronic disease management. Then I'm going to present 3 experiences of chronic disease, and these are about epilepsy and other issues, epilepsy and health care choices, and finally then the concluding remarks. So that's basically the outline of the presentation. Because it's such a big question about whether epilepsy eventually finds itself in under Chronic Disease Management Programme. So what type of research that we've been doing? It's a qualitative, semi-structured, long-term engagement with people with epilepsy, well controlled, using narrative analysis, ethnographic methods, and focus groups. Essentially, that is hearing people's experiences, understanding those experiences, and putting them into an analytical framework. And one of the things that came out was this need for a chronic disease management program for epilepsy. The research is iterative in design, meaning that we changed the design process as we went along based on what we were hearing. And this has allowed us then to have a stimulus for discussion, and it has adapted the research over the research program. We were involved with health professional interviews and group discussions. We also tested the validity of a checklist for epilepsy in care settings, and the evaluation and the development of an educational video for those working in care settings. So, chronic diseases, or chronic illnesses, whatever way you want to frame it, are non-communicable diseases, also known as chronic diseases, are usually long in duration, more than 3 months, and are a result of a combination of factors. Okay, be it genetic, for example, type 1 diabetes, I should say, physiological, environmental, and environmental factors. Okay, so this is the main tenets that we understand in relation to chronic disease and what defines chronic disease. There is some disparity of agreement with how long a person has to have a chronic condition for it to be called chronic. And often one of the things that happens is an acute episode would happen, then that turns into a chronic condition, and it can go back and forth like that. But generally, it's usually 3 months. So, chronic disease and income. So we know there is a disparity between the population in terms of its income and the amount of chronic diseases that happen within poor areas. So non-communicable diseases affect people living in low to middle income countries disproportionately, accounting for 73% of non-communicable diseases. So I think we're now headed into the framework now, or the time frame that by 2030 more people will die from chronic diseases from communicable diseases globally. And there is an estimated there's 50 million people living with 50 million people with epilepsy globally. So epilepsy is the oldest recorded neurological condition, and it's the most common. So we start to add these pictures together, that the age of chronicity, as it's called, how more people are getting more chronic diseases, that there's disparity in terms of income, and we see this actually in Ireland as well. So epidemiological data suggests the burden of chronic disease is unequally distributed by social groups. For many chronic diseases, the prevalence is higher in social disadvantaged groups, and these groups may also experience worse consequences because they're less likely to seek effective interventions and may experience poor outcomes for such interventions. So that's for a quotation from the Royal College of Surgeons in 2024 about the burden of chronic disease on the population. So even when we look at the map of Ireland, and we can see that certain areas where, in terms of the access to income per household, you see the disparity across certainly in the Midlands, so the Northwest, the Southwest, and west of Galway. And of course, we know that within the cities themselves, there are what we'd call islands of poverty, if you like. So there's disparity all across the country in terms of income. And this may affect, access to care. There might be the resources, people have the burden of having to travel greater distance and things like this. And this all adds into the chronicity that people are experiencing. So, have I gone back? No. So non-communicable diseases killed at least 43 million people in 2021 globally. So that's when remember when I said there a while ago that we are moving towards where more people are going to die from chronic diseases than communicable diseases. And it's equivalent of 75% of non-pandemic deaths related globally, if you like. Cardiovascular disease accounts for most chronic diseases, 19 million deaths in 2021, followed by cancers, 10 million, respiratory, 4 million, and diabetes, 2 million. So you can see that there's a global pandemic of chronic diseases, or epidemic, if you like. So Ireland and chronic disease management, and I suppose we have started to respond to global trends. So in Ireland, the Chronic Disease Management Programme is supports through the medical card, or GP visit card, or the Health Amendment Act card. So it covers type 2 diabetes, asthma, COPD, and cardiovascular disease. So if you have one of these conditions, you can go to your GP, you're seen regularly, maybe twice a year, and that's the level of engagement. There would be practice nurses that support people with diabetes and asthma and things like that. So it's quite a developed and thorough sort of response to the chronic disease problem. And I suppose epilepsy and so epilepsy in this, when we start to think about epilepsy now, we have to sort of think about it in terms of how it's actually affecting the person. Okay, so a person with diabetes, for example, going about their chronic disease, might be in relation to their medication, it might be in relation to the environmental factors that they're experiencing, and the support might be emotional support that's been offered, or just the regular sort of occurrence of going to the doctor to discuss their issues. So epilepsy not only affects the physical state, as you know, of an individual, but in the context of people's lives, such as the emotional and social and cultural context. Living with epilepsy is a complex, dynamic, and a multi-dimensional process. So I guess thinking about the Chronic Disease Management Programme, having that ability to see your GP regularly, having the ability to see a nurse specialist regularly, adding that sort of level of care would support this multi-dimensional process. So what begins as an acute event, like a seizure, can go on to be a chronic disease, and that is a cyclical, acute, chronic phases, changing how a person understands and experiences their epilepsy. So this is all from the literature that we would have examined in preparation for this research. So what I'm going to present now is just 3 short vignettes of 3 people that we've talked to, and it gives sort of that multi-dimensional process of the chronic illness and the experience of the chronic illness. So physical and social and emotional changes is a brief case study. So this presents this complex and cyclical sort of experience this person has had. So this person is a former cook, they're aged in their 50s, they had multiple seizures in work, and this is how it happened and how it began. It was danger in the workplace, so they had to leave their job. So falls and multiple injuries at home, had a seizure in the garden, and nearly dies from those injuries. Starts new employment, they can work from home, stability returns. This is the sort of cyclical nature of it. Stability returns, however, can't access public services because of where they're living, makes it a decision to access private services due to the waiting lists. Feels increasingly isolated at home. Seizures return, fear of not being able to drive, fitness to drive assessed. They can't drive anymore, becomes more isolated. So you can see this, so it's not just about the epilepsy, it's becoming this cyclical burden of engagement and trying to return to a stable life, if you like. Lives in a remote area, wants to leave, but will lose their support and their network. No one really wants to leave their family and friends and things like that. 9 months seizure-free, hoping for a return to normality, hoping for a normal life, and staying fit and active. So then, just turning to another case study, this person then talks about the right intervention and support at the right time. So male, early 40s, married with 3 children, epilepsy develops in early 30s, episodic night seizures at first, went undiagnosed for several months, which would be a common thing. Seizure at home, witnessed by wife, seizure at work, led to significant changes in the workplace in terms of management and the training for staff. And understanding and knowledgeable GP, offering advice and medication, sleep-work balance. So they were lucky in this sense. So the first vignette, we get a sense of this person is tackling this on their own. They're isolated, they're living in a rural area, it's difficult for them, and the challenges about driving. This person then, their work response trains people up to be able to deal with the seizures and work, makes people more aware, the GP is interested in their care, and they get all the support. All the evidence from this case study shows the support and early interventions change how that person understands their chronic illness. So if you like, if we had epilepsy under the Chronic Disease Management Programme, it would make, this is what people should be experiencing, these sort of interventions, support structures around them. And of course, Epilepsy Ireland does an amazing job in doing that. But also what we are talking about is governmental change and governmental structures that allow people to access their GPs without the burden of expense and without the burden of time. So there's time given to you. So I think with all chronic diseases, people are time poor, okay, who get waiting to see the doctor, waiting list, waiting to see the practice nurse. It is always a burden. So what this person then said, fear of further episodes, what he said is that I'm learning to live with it, but it's not easy. It could have been an awful lot worse. No one could have been there with me when they had the seizure, and no one had to talk with, if you like. It's that sense of people being able to talk about their experiences, being able to be free to talk about what has happened to them, and to be able to seek out help appropriately, if you like. And then the next vignette is really, and the case study tells us about a person reflecting back on their own epilepsy, what it's done in terms of their lifestyle, what it's done in terms of how they view themselves, which is really important. So this person is a female, they're in 30s and they've no children. I think I never talked to her about why she didn't have children. I think it was a choice more than it had anything got to do with the epilepsy. I can't really come to terms with what has happened to me, all the opportunities I've missed, the career I would have had, the loss of chances. I grieve for those chances. And that was I thought it was pretty powerful, and that's why I've included it here. It's that sense of those opportunities missed because of her epilepsy and because of what she thought her life would have been like. I didn't get any support. My GP didn't really offer support, but it's not their fault, is it? And that was a common thing. There was a sense from the others that I spoke to that GPs were doing a job and they didn't really fit into that structure of supporting people with epilepsy. And it would take someone who was uniquely interested in it. And that can happen, or someone just to be able to say, I'll help you get the support, or make the proper sort of support structures around for you, and sort of help you get to see people like your neurologists and things like that. But it's often seen as the GP wasn't seen as the perfect person to talk to, if you like. And this person go on to say, it would have been good to have support from your doctor about medication, side effects, and sometimes just to talk what has happened to me, just to talk about it without this being a thing, just impromptu. I thought that was very powerful, to be able to talk about your epilepsy without having to talk about it in some ways, to be able to engage with a healthcare professional about how you're feeling, about your experiences that were beyond just medication, beyond the things that were happening, and to be able to unpack the burden of chronic disease, if you like. I guess not talking about it makes it worse. Like when I go to the GP, it's not mentioned. What I'm meant to do, it would be better or more honest and speak more openly. And I guess that's one of the things that we know from how people experience illnesses, is that they tend, the burden of silence is very powerful. They don't want to talk about it. They don't want to be talking about how themselves, or, if you're Irish, that's a thing as well, that you don't want to talk about yourself. And it's a powerful sort of sense that being able to talk, being able to invite it to talk to your GP on a regular basis about your epilepsy would be a way of bridging these problems that people are experiencing. And I suppose what people went on to say in the research is that epilepsy and the individual brief statements about people's experiences, examples of key findings. How a person experiences and adapts to their epilepsy is dependent on the level of control, which of course is dependent on unseen things happening in the brain, how things are fine and then they're not. And these are all the words of the people that I spoke to. And I suppose this is why we chose long-term engagement with people with epilepsy over the course of 18 months to really get a sense of how people were experiencing their chronic disease. There is a strong degree of uncertainty, of not knowing of when a seizure will happen, when things could go back to normality, the way things, so adaptation is not permanent. This is referred to the transition or liminal state within the literature, and it's found in other studies in chronic disease. And I suppose one way to think about that is when people are experiencing different phases of their epilepsy or any chronic disease, what people are trying to do is get to a state of normality, always trying to get back to that state. And that sort of transitional phase can be very difficult. So often when I was chatting to people, they would talk about the fitness to drive, that sort of thing hanging over people, and who's going to make the decisions on that, and whether that could be taken away from someone or not. And it was a really important thing that we came across in the research. And it kept on coming up and up. And what it was really about, and when I talked to people about it, is that sense of control, not knowing what was happening, what could happen in the future. And perhaps a unique feature of epilepsy as a chronic disease. So going on from this, epilepsy forces people to adapt. So like going back to the vignette about the person leaving their jobs, people moving homes, changing their lives. And it also, one of the things that I heard from one person is that it changed the way they saw their material possessions. It changed the way they saw their life in terms of what they deemed sort of, I guess, we have reached a stage in all society where we judge success on monetary values and what you have. And I think when I spoke to them, they said it changed the empathy that I had for others. It shook them out of their everyday experience, and it made them see the world completely differently, if you like. And it helped them refocus not on material possession, but becoming more caring to others, which is quite extraordinary if you think about it. Support makes all the difference, according to the others. You don't know what happens when you're going to have a seizure. There's a feeling of blacking out. You worry how others respond to your seizure. Did it upset them? And this is a type of a new stigma. That sort of unknowing of what actually happened was quite clear in the research. How your doctor, and this is the key thing, how your work, how your doctor, how your family and friends responded can mean the difference between suffering and not suffering. And I suppose if we can move towards having epilepsy as part of the Chronic Disease Management Programme, you're moving towards an established pattern of behaviour and a governmental support. You don't have to ask questions. You can go to see your GP twice a year, and it's a regular thing. You can talk about things that might be worrying you. It could be about pregnancy, it could be about alcohol intake, it could be about driving, it could be about work choices. So it would be such an advantage if it happened in Ireland that we would see this happening. And I suppose this would allow people getting on with your life, and you don't want to make everything about you, as another person said to me. And I guess in the literature we call this social suffering. It's like that sort of, so you have epilepsy, you have a chronic condition, but yet the social suffering can often be the side of things that can get to people. And it's really important to recognise that. So epilepsy and healthcare, brief findings from the research. I suppose the importance of initial contact is vitally important. Support and treatment by healthcare professional cannot be overstated. So it's really important that this would be seen as a stepping stone. A central theme in the research is first contacts with healthcare professionals can change how people with epilepsy interact and seek help from different disciplines. So how you're responded to by your GP might impact how you're going to respond to the neurologist. How the neurologist responds to you is going to impact how you're going to interact with the nurse, for example. People with epilepsy feel underserved by care in general practice and rely mainly on overstretched services in secondary care. So we know this is an ongoing problem. As epilepsy is cyclical, those interviewed expressed their interest and support for GPs' involvement in their care rather than waiting to see a specialist, and welcomed the concept of epilepsy coming under chronic disease management. So people with epilepsy have expressed their need for GPs to be more involved in their care. GPs are considered as expert are not considered experts in epilepsy care, according to people with epilepsy and GPs interviewed. And I guess that is really, we have notable exceptions. So with chronic disease management, what you're hoping to achieve is that more regular attendance to your GPs, more regular and open discussions, going back to what I was saying, the things that aren't often talked about. And the relationship with the GP is nuanced, and there is more than a degree of reluctance to discuss the issue that may impact on lifestyle, for example, fitness to drive, lifestyle choices, drinking or recreational drug taking, or work choices. As with most in the room here, we tend not to seek help unless we're unwell, and the same is applied for people with epilepsy. So positive are evident in relation to, say, pregnancy and contraceptive support. So we do see that quite a lot in relation to GP care. So overall, the findings indicate that people with epilepsy attending their GPs need and want additional support. However, fear of changes to their lifestyle and only seeing their GPs in a well-controlled situation remain as barriers to improvement in care. GPs need to be more involved, especially in the first contact, and offer reassurance and support, and the challenges remain. However, there are current blueprints for success, mainly the CDM of diabetes, for example, and using practice nurses and checkups and regular supports. So we have in Ireland the means and structures in place for epilepsy to become part of the Chronic Disease Management Programme. There could be a GP lead or a practice nurse lead, or supported in the primary care structure. Having regular checkups free of charge to the patient could help in terms of dealing with medication, side effects, monitoring of the illness progression, having discussions about their illness or other health matters, and contraception and pregnancy, for example, would be very beneficial. So thank you very much.